Good afternoon. This is Charlie Krasner. I'm here with Jessica Thompson from Renown. And today we have for your entertainment three things. One is a interesting article, I hope you already ate lunch. Second is that sort of controversial article about antibiotic treatment length. And third are some new guidelines that help people institute antibiotic stewardship programs in small hospitals. So for your entertainment, what was that saying? So, my first slide, do I do that? Yeah. All right. So this was an article that got published and got a lot of attention in the New York Times. And it was in, I think it was Germany. So, they said people studied kitchen, what are they called? Kitchen, what are those things?
The sink?
Yeah, no, what do you clean it with?
Oh, sponge.
Yeah, sponges. People looked at them in the lab where they sometimes contaminate with bacteria and they study, but this was an attempt to actually look at sponges that people use. And so they gathered 14 different kitchen sponges from various people that they had at their homes. Make it a little bit smaller so I can see this. So the name is Microbiome. So basically the antibiotic, organization and analysis of used kitchen sponges. And basically they looked at this sponge and they analyzed the different layers of it. And they found millions and billions of different classes of bacteria. Some you may recognize like Bacteroides and other things like that. But it was just very impressive what they found. And what they wanted to look at is, what the next slide. They yeah, so next sponge before that. Oh, here it is. All right, so they studied 14 sponges from people's kitchens that were volunteered to them. And what they found was 360 different species of bacteria were identified. And they looked at the density of the bacteria of these sponges, and they found 82 billion, on average, 82 billion bacteria per cubic inch, which is the same concentration found in human stool. And what they said was you find a warm, wet, and nutrient-rich space to thrive in. And some of these were mostly not pathogenic bacteria, but one was called Moraxella osloensis. And it can attack people with weakened immune systems. And they said this is the cause of the stink when your sponge gets smelly. Apparently metabolizes fat and then excretes this smelly fat that you can smell. And apparently it's the same bacteria that causes gym clothes to smell a lot too. It's the same bacteria. And so they said, oh, people, either put it in the microwave, they threw it in the laundry, they put it in the dishwasher, and maybe that cleans it. And it turns out that when you do that, you nuke the weak bacteria, you kill off the weak bacteria, and actually the strongest, smelliest, and pathogenic ones survive and grow. And so they were saying it really doesn't seem to work very well when you do that. And it's very concerning. And so this was written about in the New York Times, and then the New York Times had a follow-up article where people were calling in or panicking. And so they talked to some microbiologists, and they said, what were their recommendations? One, a lot of people will, they'll use the sponge to maybe get the juices off the sink from meats, on unpasteurized food, the dirt that comes off veggies, and they use it on their pets or something. So they say absolutely don't cross-contaminate. If you're going to use it for like dishes, use it for dishes. If you're going to use it to clean your sinks, the tables and stuff, use a separate one. Unpasteurized food, use separate ones. And so do not cross-contaminate these sponges. And they recommend that you actually wash your hands before and after you use the sponge. And probably, the wetness is what allows you have wetness, you have food particles, and there are, it's basically an incubator. And so try to keep your sponges dry. And if at a point that if they start smelly, or at least once a week, they recommend actually throwing them away And they recommend, if you're really concerned, particularly if you have patients, people at home with cancer or weakened immune systems, they recommend using washable cloths or paper towels. They say a lot of restaurants do not use sponges. They use washable cloths, which they can wash instead. So it's just something to think about when next time you're using that dirty dishwasher sponge. It's got the same concentration of bacteria as stool. Doesn't sound very good. And really, so all the ways they look at it, you cannot sterilize anything, but you're going to get rid of the healthier bacteria and allow the more pathogenic one to grow. So just something to think about when you clean your dishes tonight. So this was an article that also got a lot of attention, and it was in the British Medical Journal. It was called "The Antibiotic Course Has Had Its Day." And what they wanted to do was, they basically says the traditional teaching, we always tell our patients, finish your antibiotics off, don't stop just because you feel better, because if you don't finish off your antibiotics, the bacteria are going to develop resistance. And if you go to the World Health Organization, they have a little thing for the general public saying, how can we reduce the spread of antibiotic resistance? And this is the same stuff you'll find on the CDC websites, all these sites. And they say, how can we reduce the spread? Take some simple actions. Do not use antibiotics, obviously, for viral infections. Use only antibiotics when a doctor prescribes them. But most importantly, they say, when you are prescribed antibiotics, take the full prescription, even if you are feeling better. I mean, that's always been drilled into our heads, into our textbooks as kids. You must finish off the antibiotics. And because by taking your antibiotics, you're going to avoid resistance. This article doesn't agree at all with that. They say, this article, he says, basically taking antibiotics actually induces resistance. And he says, the idea that stopping antibiotic treatment early encourages antibiotic resistance is not supported by the evidence. While taking antibiotics for longer than necessary increases the risk of resistance. And doctors need to stop advocating complete the course. What he says is that we have to take our antibiotics so that the strep or the staph we have doesn't develop resistance. And he calls that the target of the antibiotics. So you're taking penicillin for the strep, you're taking Keflex for the staph, okay? You're going to be active against those things. The ones that we're treating, like the strep and the staph, they're not going to develop resistance. But what you're doing is that whole concept of collateral damage. It's that your whole body, you're not just treating the staph or the strep, you're also exposing all the hundreds of bacteria in your body to this antibiotic. And so these bacteria may live harmlessly on your skin, in your gut, etc. But by taking an antibiotic, you are selecting for resistance in these non-pathogenic bacteria. And so even though you're knocking off the strep and the staph effectively, what you're doing is you're inducing and selecting for resistance in bacteria, which can then be passed easily by various mechanisms to other opportunistic bacteria, leading to MRSA, extended spectrum beta-lactamases, quinolone resistance, etc. So, like, for example, when we treat an E. coli bladder infection, we give them, you can use a drug like ciprofloxacin. Ciprofloxacin may get rid of that bacteria, but at the same time, you're doing a collateral damage to the rest of your intestines, and you're going to select for resistance and develop things like ESBL, quinolone-resistant bacteria and stuff. So he's saying that while we may not develop resistance in the bug we're treating, we are inducing resistance to our gut flora. And then we're actually taking these antibiotics, may treat what you got, but it's also inducing resistance in them. So if somebody comes back, next time they come in, they'll have a quinolone-resistant bacteria that you have to treat. And he says that many diseases are overtreated. We know that, especially urinary tract infections and community-acquired pneumonias. First of all, they've been having UTI. And we've talked previously, a UTI, if you really have a urinary tract infection, 3 days, not 10 days, okay? But, so that's what his argument is, that taking an antibiotic is going to lead to potentially resistance in this collateral bacteria. Really, if you're not taking an antibiotic, how can you induce resistance? So it really doesn't make much sense, If there's no exposure to antibiotics, how are you going to induce resistance? So this makes a lot of sense what he's saying, but people it's in the headlines, stop your antibiotics when you feel better. That may be true for something like UTIs or pneumonias, but there are other conditions. Otitis media, they may feel better after 5 days, but there's evidence that, treating for 10 days. Bacteremia, particularly with staph, even though you feel better, you do want to treat for, at least a few weeks, osteomyelitis, endocarditis, etc. So those are indications, for a long therapy, even though you're feeling fine. So so I think the bottom line is that, yes, taking antibiotics can induce resistance and not actually prevent resistance. But the doctor should have the patient complete the course that he's recommended, but the course duration needs to be determined correctly. It may need to be individualized for each patient.
Arlene and Jessica, does that help?
Yes, it does.
Any questions or anything?
No, yes, what we're thinking of what we're trying to get the doctors to do.
So, but just, we are, there's never been resistance to strep, even though people may have taken 2 days versus 10 days. Strep group A remains 100% susceptible to penicillin and ampicillin, but taking that antibiotic may induce the resistance in other bacteria.
Yeah, I mean, it makes sense with the literature that we have out there. For instance, the 7 versus 14 days for hospital-acquired pneumonia, you have the same clinical outcome at 7 versus 14 days. And when you look at recurrence or new pneumonia a few weeks down the road, the recurrence rate is actually the same at 7 versus 14, but you're more likely to have a new pneumonia with a resistant pathogen if you treat it for 14 days initially. And that literature is also out there, UTIs. If you treat for longer courses or if you treat an asymptomatic bacteria, you're more than likely to have a resistant pathogen the next time around. So I think the literature absolutely supports, their point of view. I think it's great that they're kind of changing the dialogue of to not use it until you take your antibiotic until it's gone.
I mean, you're always trying to make you feel guilty if you didn't take your 10 days.
Right. And it makes you question some of the things that you've learned. Like the 10 days for strep throat is, I was always taught to decrease risk for glomerulonephritis and rheumatic heart disease. But thinking back, I've never actually read a study that's been proven to be true. That 10 days versus 5 days would be prevent it more often. I don't know. There's a question.
Yeah, so taking your antibiotics does not prevent resistance. If anything, induces resistance. And so we really need to reevaluate how long we're treating patients for, not so much for the bacteria involved, but also for the collateral damage that we're seeing. And definitely they've seen, in antibiotic stewardship programs, the less antibiotics you use in a hospital, the decreased incidence of resistance among gram-negatives. So I know we use a lot of, Cipro or levofloxacin for community-acquired pneumonia. The quinolones are going to induce problems with C. diff. They can induce problems with, you'll get rid of the pneumococcal pneumonia, no problem, but it's going to have a collateral damage to developing Pseudomonas, quinolone resistance, E. coli resistance, etc. So don't believe it when they tell you it reduces resistance. It takes care of the infection, but does not, it actually precipitates resistance. So that was an interesting thing. So what I wanted to talk mostly about today is that, we've, for the last 2 years or so, we've been talking about antibiotic stewardship programs and the core elements. And, it can be difficult in a small hospital to set up these programs. And so the CDC came out with these updated guidelines, which they just published. You can just write implementation of antibiotic stewardship core elements in small and critical access hospitals like you guys are. And what they did was, the last year or two, they've gone around, the CDC has talked to people in these different hospitals and said, what have you done successfully or not successfully to implement the core elements? Basically what works. We can list all these things, but what tips do you have that we can give to other people to show what has been successful in working at a small facility to facilitate setting up a successful antibiotic stewardship program? So they haven't, this is not new elements, it's just how do you actually implement it, and some tips from a lot of small hospitals and critical access hospitals. What have they done to successfully implement this program? And so I just wanted to it's really worth going out. It's only about 4 pages, and they list for each of these elements what are some of the things that they're doing. And so I was just going to go through some of them the parts of the 7 elements. And so for core elements, number 1 and number 2, leadership, commitment, and accountability, some of the standard things: get a leadership statement to all providers and patients highlighting the hospital's commitment to improving antibiotic use. So just get a statement, let the patient see, let all your providers see that you are committed to this program. They recommend getting a physician, should either the chief medical officer at a small facility, that can be accountable for the outcomes of the antibiotic stewardship program. Because you really want somebody who is responsible to make sure that these are implemented. They recommended your physician, if he agrees or she agrees, to be the one accountable for the outcomes. Again, they also found helpful enrolling in multi-hospital collaborative efforts to improve antibiotic use. Sort of like this ECHO program, but there's other programs also available so that you can share things you're doing. They recommend funding remote consultation with experts in antibiotic stewardship program, either physicians or pharmacists. Again, you have us available if you're interested in discussing some of these issues with it, but getting a remote consultation, because most hospitals don't have infectious disease people involved in their facilities. And they also say if you're going to have an external pharmacy service, in your contracts with them, require their contractual responsibilities for formal stewardship, not make it part of their payment and their obligations that they're going to be involved in providing pharmacy services. So you really have to, again, you have to say you're responsible, this physician's responsible, this pharmacy service company is responsible. So you really have to designate somebody who has to be responsible. And not trying to do it all yourself, either getting remote consultation or multi-hospital collaborative efforts to improve antibiotic use. And again, the drug expertise, that can be difficult in a small hospital. You have the leaders of the antibiotic program participate in educational programs and through participation in multi-hospital stewardship collaboratives. So participating in multiple small hospitals and raising issues and discussing things can be helpful. But this is probably the biggest thing, the core element, taking action. And again, what we've talked about, I've seen, some of these antibiotic stewardship programs, they talk about the management of multi-drug resistant, Acinetobacter, things that aren't really relevant to what may be going on in a small hospital. And so what you really want to do is focus on what is most important in your facility and decide on which interventions to implement must be based on local needs. If you have particularly, mostly a skilled nursing facility, maybe urinary tract infections or the overtreatment of asymptomatic bacteria may be the biggest thing for you, okay? And they say in small hospitals, there's really only 3 conditions that represent the vast majority of conditions. And these things we've talked about. 1 is community-acquired pneumonia, okay? 2 are urinary tract infections, and 3 are skin and soft tissue infections. So we're going to talk a little about that, but here's what they recommend for, example, using community-acquired pneumonia. First, they recommend, for example, patients admitted with pneumonia, the diagnosis of pneumonia, should be reevaluated at 48 hours to confirm pneumonia diagnosis versus non-infectious etiology. My experience is probably 30 to 40 to 50% of patients, quote, pneumonia, really come in for other reasons, whether it's, mostly it's heart failure or something else like that, fluid or congestive heart failure, or oftentimes misdiagnosed. And so it's definitely worth sitting down. This guy's on antibiotics for, quote, pneumonia. Is this really pneumonia? I mean, does he have a white count? Does he have a fever? How much oxygen does he require? Do we have any positive cultures? And if they're all negative, even, somebody doesn't have a fever or a white count, he almost certainly doesn't need antibiotics, okay? And so it's really worth it, not just saying he's got pneumonia, reevaluating, okay? Because many of your patients are not going to have pneumonia that come up with that diagnosis. And then, so review the cases at 48 hours. 2, guide in empiric therapy, okay? Again, avoid empiric use of, the combination of vancomycin and azocin, okay? Very few of these patients have MRSA, so you probably don't need the vancomycin. And the community-acquired pneumonia, they're not going to come in with Pseudomonas unless they're in and out of the hospital. Then you think about healthcare-associated pneumonia. But your average patient, especially at smaller hospitals where you're not dealing with tertiary issues and stuff, or cancer wards. You don't need pseudomonal coverage. Again, going back to this whole idea of what we were talking about is you may be, the zosyn may treat pneumococcus, but it's also exposing the other bacteria to a broad spectrum antibiotic that's going to probably induce resistance in them. So guide empiric therapy, okay, and say, this is what we should be using is, Rocephin and doxyrocephin and azithromycin and kate, unless we have, the following things. The guy, it's 106 degrees with cavities, and you think about vancomycin adding, okay? So help people empiric use of appropriate antibiotics based on the guidelines, okay? So guidelines, even if you put them on Rocephin doxy, then come back 2 days later. Is this really pneumonia, or is this just heart failure? And third, what you can do is assess duration of therapy, including discharge treatment. The guidelines have uncomplicated pneumonia been shortened to as few as 5 to 7 days. Okay, they don't need 10 days or 14 days of levofloxacin or something else like that. Okay, so this is what they're saying. These are the problems you're going to see in a small hospital: community-acquired pneumonia, and I don't list it here, but they also go on for urinary tract infection. Again, what we've talked over and over again in this clinic is, is the patient symptomatic? Is it just asymptomatic bacteria? Again, teaching your nurse not to send off urine cultures just because the urine is cloudy, okay? And if you're going to treat for urinary tract infection, don't do 10 days of ciprofloxacin, use the macrodantine and stuff like that. And then the third one, again, is the soft tissue infections. And over the years, we've talked over and over again, if you don't see pus, you don't need vancomycin. You can just treat something simple as cephazolin, okay? So I think if you, instead of saying, oh my God, how am I going to deal with all this? If you pick 1 or 2 topics, either community-acquired pneumonia, urinary tract infection, or cellulitis, and look at it, break it down, people find this very helpful and can make a very big difference in the management of these patients.
Can I comment on number three here, the assessed duration of therapy, including discharge prescriptions? I've not verified this, but I'm almost positive that if a patient remains admitted for their treatment course of pneumonia, my theory is that they actually get a shorter duration of antibiotics than if they were discharged before the end of their duration, because it's almost always 5 to 7 more days on discharge, no matter if they're on day 2 or day 5 or day 7. I think that's a huge opportunity for stewardship, is possibly even from a medication reconciliation standpoint and intervention on discharge to prevent some of those prolonged durations of therapy.
Yeah, I mean, usually 2 days without fever and feeling better, the treatment's almost over with.
Yeah.
All right, so they just, again, if you go to this handout, it's really nice. It really gives these sort of like practical guidelines, picking a topic and just picking 2 or 3, diagnosis, the diagnosis is correct, guide empiric treatment, make sure it's appropriate, and then stop treatment early if it's not, once they're doing better. And so then, obviously, tracking. You want to track adherence to your treatment recommendations. At Northern Nevada, we make a recommendation, and then we find out if they agree with it, if they follow it. So you definitely want to show some kind of objective feedback on what you're doing. Work with your infection control program or your infection control practitioner to track data on C. diff cases and antibiotic resistance infections. And the CDC has an online thing called the antimicrobial use option that allows you to actually put all your data and helps you organize your data, which would be very helpful. And there's a link to that on this handout. So again, you want to track adherence to show that you're making a difference, that things are being followed. Work with the infection control program to track C. diff particularly.
The antimicrobial use option, I'm assuming that's the NHSN.
Yes.
So most of your facilities already report to NHSN. The downside to this antimicrobial use option is there's no manual input. It requires a computer-to-computer transmission. And for instance, our electronic medical record is not built to do that yet. However, they have a really nice document on what they're looking for, and you can create a report using their guidance to monitor month to month or day to day or amongst the floors. So compare with your own institution, even if you aren't able to report directly into NHSN. It's a really useful document, I think.
And then, you say you're a small hospital, you know, I work at Northern Nevada, which is a small hospital. I work at some bigger hospitals. And actually, I find education much easier at a small hospital because, you know, you're just, you know, you're dealing with anonymous hundreds of doctors. No one's going to listen to you. But when you have a personal relationship with, you know, the few internists or family practice docs or the surgeon, you can get to know, you know, you can talk with them, you can collaborate with them, you can explain to them what you're going on. So I think it's much easier in a small hospital actually to educate people. This is the comments other people say, you know, with limited number of providers and a more collaborative nature at these small hospitals, you can really have an advantage in education, in educating your individual providers and giving feedback. And, you know, I think people are much more collegial in small hospitals because they know each other, you know, they have lunch together. And so I think it's much easier to actually get to bring change about in your antibiotic programs. You know, in a big hospital, the hospitals are changing all the time. They may have little involvement in their hospital. Nobody really knows what's going on, and they're more anonymous. But I think when you're a small hospital, they know you all work together. Most people are knowing how other doctors are doing. I think it can be easier to work there. And then you can have your nurses. You know, the nurses, there aren't that many nurses in a small hospital. You can specifically talk to them about, hey, you have a patient who's been on Cipro for 2 days IV. How about talking to the pharmacist or your physician about switching to oral conversion or any, so they can start looking for criteria for getting, you know, reminding, you know, the patient's doing well, able to take orals, fever gone, can we switch to oral treatment? And also when to collect urine samples, educate patients on the risk of antibiotics, et cetera. So I think a small hospital actually has an advantage over a bigger one where you have a more collegial environment and less people that need to be educated, and you can do more on a one basis. So I know it sounds overwhelming. I hope some of you have started doing your programs, but if you go to this website, these are just samples of some of suggestions we're making. I think you can find ones that will fit you really nicely. And I do think at most small hospitals, it's, you know, it's community-acquired pneumonia, urinary tract infections, and soft tissue infections, which are probably, you know, 90% of why patients are in the hospital. And you can pick one of those to work on. So anything you want to add to that?
I agree 100%.
Yeah. Yeah. So, you know, the CDC, this thing is very helpful because it's really a practical how to implement it and how to do it. And I think once you actually jump in and start doing it, it's not that difficult. And working on a personal level with the physicians, and you can really make a big change. And I think, you know, in Northern Nevada, it's been, we all get along well, and we'll be able to make changes much more nimbly than we could at a larger hospital. And so I think it's been helpful. Do you guys have any comments about your own programs that you want to share?
So Dr. Kara, and I just want to say we were one of the hospitals that participated in making that, so that was a neat experience for us.
Oh, nice.
Who called you, or who did you talk with?
Aaron O'Leary at the CDC.
Cool. Yeah, so this is, it's unusual to see something practical actually printed, you know. And so I just think it'd be, how has your program been going?
Really well. Actually, we have our program meeting right after this every other month. So we meet on a bi-monthly basis, but actually has been going really well. And we're just trying to work on, you know, what can we do better? And I just went to that caucus on Tuesday that was on the antibiotic stewardship all day. So I'm bringing a whole lot of that back to the meeting today.
Can you share some of your successes that you've had?
Oh gosh. One of the things that we're working on right now that has been kind of one thing I'm proud about is we're bringing that back. We got our board of directors on board with us and our CEO, so that was a very big step for us at first. And now what we're doing is working on our antibiogram. We are fortunate enough to have our own antibiogram, and so we are working on now making a feedback loop with that, and bringing to our meeting today a letter that I drafted to go out to our physicians for the outpatient areas, and give them a copy of the antibiogram, and when we're doing our culture logs, to look at the antibiogram and see if the susceptibility is good or not, and then give that feedback letter back to the physicians either by fax right away so they can change it and that kind of thing. So that's one of the things that's taken us a long time to get up to that point. So that's one of the successes I've been happy with most recently.
That's great. That's great to get leadership, and then it sounds like you're doing some awesome things.
Yeah, and that's how you could use to show them, because they look at an antibiogram, their eyes probably, fuzz over. But you could show, why you're recommending, macrodantin versus ciprofloxacin, okay? So, they say, oh, macrodantin, that's just an old drug. Oh, look, it's 96% susceptible against our E. coli. They go, oh, look at that. I didn't realize that. And then you can make a suggestion, give it 3 to 5 days, not 10 days, okay? So that's very good. It'll be interesting to see how they react to it. I think you just need to show your evidence, and the doctors will hopefully agree and work with you. Oh, good for you.
You're unmuted. For Boulder City Hospital, we have the IV to PO. That's our successes, and the I can't say it.
Antibiogram.
Just got it.
Our antibiogram, we've done it a little differently for our facility because we don't have that many positive cultures that the counties doesn't even include us. So what we've done is when we get our cultures back, we go and add the culture report to our antibiogram that we do by hand. And we have like three urines and maybe 14 urines, 2 bloods, and cutaneous. So we've given them something to look at to see exactly where we're at. The doctors, that is.
But they've actually started asking for it.
Yes.
We were very excited when a physician from the ER asked for one.
That's awesome. Who's doing your IV to PO protocol? Is it nurses or
Pharmacy.
Our pharmacy.
your pharmacy?
And then also with the pharmacy, they have extended the IV antibiotic infusion rates. So that just started this month.
That's awesome. You guys are doing some great work too.
Another little thing that we're trying to do over at North Nevada is, ask your pharmacist, people come in on, omeprazole, those PPIs. Patients don't know why they're on it. They're probably discharged from the hospital 5 years ago and they're still on it. Definitely, you can do a patient a favor, getting them off those, say, do you really need this? Or look into it so that the patient says, I don't know, I just take it because I get it. Okay, there's a lot of long-term problems with PPIs, not just, C. diff, but, there's issues of bones and brains and all that stuff. And so, it's just something else you could do to help your patients out. But PPIs, definitely seem to increase the risk for C. diff for hospitalized patients when they get out of there. So that's something that's pretty easy to do, but I think it's actually helping.
So there's a question here. How many facilities are using the interfacility infection control transfer form that was discussed at the summit on Tuesday?
This is Kara. We are not using it yet, but I'm bringing that to our committee today to talk about that, implementing that.
We are not using it, from my understanding. I think it sounds like more Southern Nevada facilities are using it, and I honestly don't know what all would be involved, but from my understanding, there is some duplication of information they're asking for with some of the forms that we already complete. But I'm curious to see how it goes. Let us know how it goes, and I don't think it's something that we are necessarily against. It's just we haven't taken it up yet.
I need to run, but let us know what you'd like to talk about next time. If you're, as I said, if UTI, simple guidelines for UTIs, we've done them many times, or cellulitis, something like that.
Classes of antibiotics.
Mostly when they apply, when it actually applies to the infections themselves. Yeah, but I'm willing to talk about anything you'd like besides sponges. You want to send me pictures of your sponge? We can show it for show and tell. All right, I got to run. Thank you, guys.
Thank you, guys.
Thank you. Poopy start.